pass it around for everybody. So.
Oh, how nice.
We're done. I'm going to introduce. Yes, I'm going to introduce Dawn Kolderman. She's the director of palliative care. We are honored to have her here to give us a talk and interaction with everybody. So when she is giving you the presentation, by all means, anybody who wants to have any questions, that's basically what she's going to do, an interaction with everybody, okay?
Thank
Dawn,
you.
thank you for being
Thank
here.
you. Good morning, everyone. Thank you so much for having me, Oscar and NCH, of course. My name is Dawn Kolderman. As Oscar said, I am a registered nurse. I have been working for the Avow companies for about 18 years now, and I currently oversee the palliative care department, as well as our bereavement department and all of our children's programs. I'm very honored to have this position at this point because I found the biggest struggle in this community was educating the difference between hospice and palliative care, because we are generally used synonymously and we are two totally different programs. The easiest way for me to define the difference is this. Palliative care patients are any individual that has been diagnosed with a life-limiting disorder. Very, very broad term. It is generally patients that have a cancer diagnosis, a pulmonary disease diagnosis, a cardiac diagnosis, dementia, okay? These are all disease processes that will likely, potentially, limit your lifespan. But you are seeking aggressive treatment, you are seeking specialists. Most of my patients, or some of my patients, are receiving chemos, radiations, going to multiple different hospitals, different medication trials, things of that nature. You also continue to see all of your specialists, your pulmonologists, your cardiologists, okay? On the hospice side, generally speaking, you are not doing those things. You have decided, for a numerous number of reasons, that you are seeking comfort care only. Your disease has progressed past treatments, things of that nature, okay? Very, very different programs. Hospice is much easier to understand for a lot of individuals because it's kind of cut and dry. Although patients on hospice, we do know, live longer and can seek some kind of treatments. But we're not going to talk about hospice today. So palliative care, basically, its basic term means a holistic approach to a life-limiting disease. Again, my patients are seeing their specialists, their primary care doctors, seeking aggressive treatments. They come to us because my medical providers concentrate on the symptoms that you're having related to that disease. Okay, so what does that mean? The most obvious, of course, is pain. There's also difficulty breathing, anxiety, difficulty sleeping, restlessness. Sometimes you have nausea and vomiting. Sometimes there's constipation or diarrhea related to the management, of that disease. For example, we talked about cancer. Probably 80% of my patients have a cancer diagnosis. Pain usually goes along with that treatment, right? My specialists, my nurse practitioners and physicians concentrate on the pain element. We don't cross lines. We don't step on toes. We work in collaboration with your providers, okay? My patients also have the benefit of seeing a social worker. Again, a holistic approach. The social worker works with my patients, their families, their caregivers, their support system to talk about how this disease is going to affect them today, tomorrow, and in the future. How does it affect the family dynamic? Okay, sometimes it's financial, sometimes it's just psychosocial. We talk about advanced care planning, okay, making sure that everyone kind of has their ducks in a row. What are your goals? And how can the social worker help you in that respect? rounding out that holistic approach is our chaplain. So our chaplain has the ability to really meet, again, my patient and their family. It's very family oriented. We really like to see who's the key players in our patients' lives and involve everyone. So the chaplain will really meet my patients where they're at their spiritual journey, okay, or any kind of existential journey. It doesn't have to necessarily be a formed religion type, okay? But Chaplain Deb goes out, meets with our patients. She sees all of her patients in their home. Why is that? While 75% of my patients come to our clinic, we do see some patients home if getting to the clinic is too challenging. She prefers to see all of her patients at home because she feels that's where she's going to have the most in-depth, honest conversation is in a patient's home. Social worker can do the same thing for that reason. So again, well-rounded program. We also have the benefit of having a nurse navigator. And Brian Hopkins, who's my nurse navigator, his role is making sure that my patients have everything they need in the community. We are very blessed to live in Southwest Florida, specifically Collier County, where there are a lot of resources available to us, but we don't really know where to find them necessarily, right? So Brian's role is to help my patients find the resources they need. Those resources could be difficulty with transportation, food insecurities, housing insecurities. Sometimes it's getting durable medical equipment. Sometimes it's hard to find a pharmacy that has their medications. That is Brian's role as the nurse navigator, is to really help my patients get what they need from the community. Okay, again, very well-rounded program. I have 3 full-time nurse practitioners. I have a physician, Dr. Ryan Pertzak, and we also partner with NCH, and we have the fellowship program for hospice and palliative care. Dr. Pertzak runs that program, and the fellows come through a vow on all of our different programs so that they can see the patients and they can see, how the program works, the purpose of the program, things like that. Again, really well-rounded. So how can we help most of the individuals in this room? I know have a cardiopulmonary disease or disorder, so how do we help? You obviously will continue to see your pulmonologist, go to your cardiac and pulmonary rehab, continue to seek out groups, obviously like Oscar's group here, for support and different information. But if you're starting to maybe have a little bit more struggles with the breathing, the disease continues to progress, again, you're going to continue to see all your docs. We're never going to take them away. We are another layer of support. We get all the records from the providers. We put all that information together. You meet with one of my providers. That first meeting is about 60 to 80 minutes long. He or she will sit down with you, go through everything step by step. We do a complete medication reconciliation, because what we have found is when individuals are seeing multiple different doctors and Dr. A is ordering this and Dr. B is ordering this and Dr. C is ordering this, no one's kind of really put it together. So we want to make sure that we know exactly what my patients are on. And then again, we talk about goals of care, and if this disease was to continue to progress, what does that look like for you down the road, and how can we help you now, and how can we help you in the future? So that is basically the premise. I mean, I have patients as young as 8, and my oldest patient right now is 104. And she's not going anywhere anytime in the near future. She said she's outlived 2 husbands, and she's going to continue to thrive. And she comes to my office because that's her outing for the month. So she has somebody drive her to the office. As I said, 75% of my patients are seen in the clinic. My clinic is on the campus of Avow, which is on Whippoorwill Lane. It is not just hospice, believe it or not. It is a 22-acre campus. We have 5 buildings on our campus now, and palliative care is in one of the front office buildings. We also have an office in Immokalee on Boston Avenue. We know the Immokalee area is a very underserved community, and it is our goal to help that community. We have an office that is opening on the 18th of this month on College Parkway in Fort Myers. Okay, I have about 511 patients right now on my roster, and over 200 of them are in Lee County. So we will be moving on to College Parkway. And then probably by May or June, I'm going to have an office in LaBelle as well. I have patients that come as far as Tampa, and I have patients on the other coast that come from West Palm Beach. So we're trying to really find, locations for everyone so that we can really meet the needs of the community. Again, I can sit here and talk about this all day long. So what questions can I answer for you? Yes, ma'am.
I have a question about, it says where you bill to Medicare,
We're Medicare Part B.
but that's what I want to ask. I have Medicare, but I also have an Advantage plan,
Yes, ma'am.
which is Blue Cross Blue Shield.
Right.
And they're very possessive or whatever of your account.
They are very possessive of their account. So
But-
we do have providers that we accept Blue Cross Blue Shield wraparounds or supplemental plan. Yeah. So that's a good question. So thank you. Unlike hospice is covered under Medicare Part A, it's a completely different benefit. On the palliative care side, we are covered under Medicare Part B, like boy, like any other doctor's office or any other specialist office, including your wraparound and your Advantage plans. Yes, ma'am. Yes. Yeah. Well, I have a lot of Blue Cross Blue Shield patients right now, the wraparound HMO, PPO, and EPO. So you just have to make sure that the provider, what happens is when you call the office, for example, to make an appointment, we take your insurance information, the billing department literally runs it, and yep, we check it, and it'll tell us what providers are on your network. And I can tell you that 3 out of my 4 are, and the 4th one has only been in my practice about 9 or 10 months. They still haven't kind of crossed her over. So we're just waiting for that. We also accept Medicaid, Florida State Medicaid, as well as we offer a lot of financial, assistance. Avow is a nonprofit organization. We've been around for 45 years, and we will not turn someone down for their inability to pay. So we do have a wonderful foundation, and we do a lot of charity work in the community. Yeah.
In order for a person to see you, is it the doctor who recommends?
Yeah, so sometimes we get referrals from specialists, sometimes primary care physicians, but patients themselves can call at any time and say, I've heard about your program, because then what we will do is we will create a chart for you and we will contact your provider and get the records. But we get referrals from a variety of sources, from the hospital itself, from primary care docs, from specialists, word of mouth. But you can call, personally, and then we will go out and we will get your records for you. Yeah, so that's not a problem at all. Any other questions?
If you have one or more progressive diseases,
Yes,
is it best to see you at an early stage or
Yes.
a later stage?
early. The earlier, the better. And the reason for that is our goal is to formulate a relationship with you to find out exactly what your goals are so that we can continue to follow you as these diseases progress, so to speak. And let's just say your goal at some point maybe is to be on hospice at the very end of your life. We know that hospice, you have to have a diagnosis if it continued to progress 6 months or less, although patients are on hospice for many years, but every 6 months we recertify you. Then that's the common goal. Then we've developed and we nurture this relationship so that when it's time to have that conversation, we've been talking about it the whole time. So it's a comfort level.
So sort of coordinate, oversee, like I have medication from this doctor. Right?
Yes.
You oversee and, I have to see several.
Right. Mm-hmm.
So you oversee the whole thing.
We oversee the medication reconciliation. We don't step on toes. We're not going to say your cardiologist put you on this. We don't think you should be on that. They may say to you, hey, does he know that your pulmonologist put you on this? So just to make sure that everyone is on the same page. Anytime a patient is seen in my office, we send a collaborative report to each one of the doctors you've asked us to so that we all stay on the same page. Because we have found that they're not always all talking together, and it's nobody's fault. It's just there's a lot of providers and a lot of things going on. And that sometimes things don't get taken off or added on medication lists, or they're being taken incorrectly, which is more common than not. So it's, again, another set of eyes, another set of hands. It's somebody else that you can call 24/7 if something's going on. And it's just a supportive environment is basically, what it is. We will see, as I said, patients in their home that are homebound, or it really is difficult to come to my office. We have the county split up in 4. By zip code, it is a large county. For continuity of care, we try to make sure it's the same person every time. Yeah. Yes, sir.
So one brief story.
Yes.
So, and I apologize, I came in a few minutes late.
That's okay.
If I were to get the procedure,
Yes.
I would still be at that hospital for approximately 3 months after this. Assuming all goes well, I go home. Do you have a short-term in-home type of program for help with post-op patients?
No. And the reason I say that is because we cannot provide 24-hour care. We cannot provide things like that. But we do also own a home health company called AmeriCare. And
not 24 hours, but somebody to come in.
Right.
3 days a week to help with it. Somebody mentioned medication. It's very complicated. Help with that. Help with PT.
Yeah. We do offer PT, we offer OT, we offer DME equipment, any kind of equipment you need. We can order those things, but as far as having more hands-on physical care, we cannot, because again, we're like a specialist office, but we partner with, as I said, AmeriCare, and they provide those services for us. They are a home health agency that Avow does own. So we partner with those for wound care and things like that. And congratulations, I hope that goes quickly for you and it all goes well. Any other questions? Wow, it's a quiet group. Well, I thank you very much for allowing me to come and speak to you all today. I will leave some of my business cards in the back if anyone has some other questions that you'd like to ask. Please feel free to call my clinic or my office at any time.
Thank you.
You're welcome.
Thank you very much. We really do appreciate that. Thank you, Brad. All right. Again, I want to say thank you to everybody for the participation, for coming, participate with all these meetings, and make all this possible. I want to say thank you, especially my debt of gratitude to the Pulmonary Rehab staff members, okay? Especially on this week, which is the Pulmonary Rehab Week. Let's give them a round of applause because they do a wonderful job, okay? With all the information, with all the care that they give us, they try to keep us, especially on my case, everybody, I don't know if everybody knows, but for those that know and the new ones that are here, I have a double lung transplant and I've been in the program for 6 years now, okay? Even though after the lung transplant, I'm continue doing my exercises to maintain my body, okay? I feel good. Every day I say thank you to the donor. Every day I say thank you to God, to my doctors, to the team, the NCH, because with the help until the day after, the day before my surgery, I was doing my exercises over here. And that made a big difference for me. That was a huge difference on my recuperation, on my recovery, and how fast I was out of the hospital. So by all means, thank you to everybody. We really do appreciate that. Thank you. Let's have something to eat, everybody. Make sure that everybody's got something, okay?